Question. A 58-year-old male with a known history of hypertension, type 2 diabetes mellitus, and chronic kidney disease, CKD. Stage 3 presents to the emergency department with sudden onset of confusion, slurred speech, and right-sided weakness. His blood pressure is 210 over 120 millimeters of mercury. Heart rate is 98 BPM, and his glucose level is 300 milligrams per deciliter. A CT scan of the head reveals a small ischemic stroke in the left middle cerebral artery territory. Laboratory results show elevated serum creatinine, 2.3 milligrams per deciliter, blood urea nitrogen, BUN 35 milligrams per deciliter, and potassium levels, 5.8 milliequivalent per liter. What is the most immediate intervention to address this patient's acute medical needs? A. Administer intravenous labetalol to reduce blood pressure gradually and initiate insulin therapy for hyperglycemia. B. Begin intravenous thrombolysis (RTPA) to reverse ischemic damage while controlling blood pressure with antihypertensives. C. Start intravenous nitroglycerin to lower blood pressure rapidly and initiate dialysis for the elevated creatinine. D. Administer intravenous antihypertensive agents, for example hydralazine, followed by oral anticoagulation therapy for stroke prevention. Answer. A. Administer intravenous labetalol to reduce blood pressure gradually and initiate insulin therapy for hyperglycemia. Rationale. This patient is presenting with an ischemic stroke, with significant comorbidities, including uncontrolled hypertension, diabetes, and chronic kidney disease, complicating the management. The most immediate concern is the critically high blood pressure hypertensive emergency, which must be controlled to reduce the risk of hemorrhagic transformation or further ischemic injury. Intravenous labetalol is preferred because it can lower blood pressure gradually without causing a rapid drop that could worsen cerebral perfusion. Stroke treatment guidelines recommend blood pressure reduction to less than 180 over 105 millimeters of mercury in the setting of ischemic stroke, but this should be done cautiously to avoid hypoperfusion. Hyperglycemia should also be addressed immediately to avoid exacerbating neuronal injury. Insulin therapy is necessary to control glucose levels and improve outcomes. Administering intravenous thrombolysis, RTPA, could be an option for patients with ischemic stroke, but requires a precise 3-4.5 hour window from symptom onset, and this patient's presentation and comorbidities may make RTPA contraindicated due to the potential for complications like bleeding. Nitroglycerin or hydralazine would not be appropriate for this patient, particularly given his CKD and the need for careful management of blood pressure and renal function. Finally, initiating oral anticoagulation therapy is not indicated at this point since the stroke is ischemic, not thromboembolic.